good morning, everyone. Hi, Jasmin. Uh,
Hi.
hi. I'm Pauline from Clinical Oncology Department, and this is the Jasmin, my esteemed colleague. Thank you so much, everyone, for joining our breakfast at UMHealth. And I think this is an online CME where all of us from different specialty gather to learn something new, and especially in this ever-evolving field of medicine, and we get updates wherever we are while catching breakfast, hopefully. And how we going to go about this is we will start with a short round introductions, and then Jasmine will present her case. And then you can type your questions in the chat box where we can address later at the end of the presentation, or you can raise your hand. Maybe we can also address in the Q&A session after the Jasmine's presentation as well. All right. So again, I'm Pauline from Clinical Oncology Department, clinical oncologist, and then maybe we can introduce Jasmine to give a brief description of herself. She's a bright star of our department who has kindly volunteered or to present this morning. And maybe you can ask her why did she choose this topic personally. All right. Thanks, Jasmine. The floor is yours.
Thank you so much, Dr. Pauline, for the kind introduction. Hi, everyone. Good morning. I'm Jasmin. I'm in my final year of training. Today's topic, I think, really underscores the importance of time in management of oncological emergencies. So I think without further delay, let's get started. I will be sharing my screen. So today we'll be talking about the ticking spine, timely referrals for cord compression. So we'll start with a case to sort of ground today's discussion. We have Mr. B. He's a 65-year-old smoker. He came in with cough and weight loss for 2 months. 2 weeks prior to admission, he was having bilateral lower limb weakness. By the time he came to us, ECOG was 3. There was reduced air entry over his right lung. Both legs were flaccid, and he has a sensory level at C7. You can see the chest X-ray on admission shows a massive right pleural effusion. It was drained, complicated with a pneumothorax, which subsequently resolved a few days later. In the ward, he underwent a pleuroscopy, and pleural biopsy of the nodules showed a lung adenocarcinoma. So 2 weeks in, he had an MRI whole spine to investigate, and you can see here, as pointed by the red arrow, a cord compression at level of C7. On axial slice, there is an enhancing soft tissue lesion completely obliterating his spinal canal. So he was started on immediate corticosteroids and referred to spine team and to oncology. So we'll get back to Mr. B later after we've understood the broader concept of malignant spinal cord compression. So malignant spinal cord compression can happen to up to 10% of cancer patients, mostly in breast cancers, followed by prostate cancer, lung cancer, lymphoma, and multiple myeloma. Why is this important? Because early recognition of cord compression can differentiate between a patient that walks out of the hospital or never walks again. So the main culprit would be metastasis to the vertebral body that erode into the canal and impinge the cord. They commonly affect the thoracic spine, followed by lumbar spine, and rarely cervical spine. Patients present early with back pain, mostly at nighttime and radicular in nature. As it progressed, they develop lower limb weakness or upper limb weakness, sensory loss, and difficulty walking. In the later stage, they would have bladder and bowel dysfunction followed by paralysis. The red flag sign would be new back pain in any cancer patient that warrants urgent investigation. So NICE and ESMO guidelines recommend MRI whole spine to be done within 24 hours of suspected diagnosis. If there was no previous diagnosis of cancer, of course, we should establish a tissue diagnosis, send off blood investigation like calcium and tumor markers. If we suspect multiple myeloma, send off serum electrophoresis, urine Bennstrom protein, a skeletal survey, and of course, don't forget infection or inflammation. If we suspect cancer, of course, order a CTTAP to look for a primary site. Initial management include corticosteroids, proton pump inhibitors, DVT prophylaxis, immobilization, and referral to the spine team for urgent decompression surgery. Patients would have better outcome if they were fit, not paraplegic for more than 2 days, with a predicted survival of more than 3 months. So management of cord compression is truly teamwork. Everyone plays an important role in improving patient outcome. Surgical decompression is not for all patients. I think careful selection is needed. We often use the Tokuhashi scoring system to predict prognosis, balance surgical risk against potential benefit. Also, we fall back to this trial by Pachel et al., which proved that surgery followed by post-op radiotherapy is superior than radiotherapy alone in patients with cord compression. So let's dive into this trial a bit. So this trial was published in 2005. They've randomized cord compression patients to two arms, either surgery followed by post-op radiotherapy or radiotherapy alone. And they found that a significantly higher proportion of patients in the surgery and post-op RT group could maintain and some even regain ambulation, and the duration is longer. So they've concluded that surgery followed by post-op radiotherapy is superior than radiotherapy alone. So let's talk about radiotherapy. Radiotherapy is a technique where we deliver high radiation to the area of interest. We can use the 2D or 3D technique. Doses can vary from 8 gray in 1 fraction over 1 day, 20 grays in 5 fraction, or even 30 grays in 10 fraction over 2 weeks. And it's just interesting to note that radiotherapy referral commonly happens on Fridays, and it's proven by a UK paper by Pottsman et al. So the next few slides, I'll walk you through how we perform radiotherapy. We start with simulation, which is a process of obtaining images for our planning. It ensures immobilization and reproducibility during the treatment. This is an illustration of our 3D radiotherapy technique. You can see a single posterior field here treating the lumbar spine. And these are actual photos of our radiotherapy suite. We have two LINAC machine. Patients lie on the couch and the radiotherapy beam comes from the gantry head. So during and after radiotherapy, patients should be monitored, pain should be addressed, refer to the physiotherapist, consider bone targeting agent, and of course plan for their subsequent systemic therapy. So let's go back to Mr. B. So Mr. B completed radiotherapy from C5 to T1. You can see this is his actual planning images where we gave a single posterior field, and the green line is the 95% dose covering the cord, and on the axial slice you can see that it covers the soft tissue component obliterating the spinal canal. So unfortunately, after he completed radiotherapy, he passed away a few days later. This is his journey from admission, where he already had neurological deficit, and 2 weeks later he was referred to us, completed radiotherapy, but passed away after a month in the hospital. So just to compare, we also had another case of a young lady extensively treated breast cancer, but witness was only for a few days, managed to have a PET-CT which showed extensive thoracic to lumbar bone metastasis. She completed radiotherapy and amazingly could walk a week after completion of radiotherapy. So I think in conclusion, malignant spinal cord compression is an oncological emergency. Timely recognition and early referral can actually improve patient outcomes. Of course, MRI whole spine ideally should be done within 24 hours of suspected cord compression, and early coordination between the teams is important. So remember everyone, every hour counts. Do not miss the ticking spine. Thank you very much. Over to you, Pauline.
All right, thank you, Jasmine, for the interesting case presentation. I don't see any questions yet in the chat or anyone raising their hand, but maybe we can get the ball rolling by asking you some questions. I think you
Sure.
did. So you mentioned that in NICE and ESMO guideline, of course, MRI is important, but we also do see that your patient, the second case of who didn't have an MRI, did actually receive radiotherapy. And in this resource tight setting, especially in like government hospital, uh, what are the challenges? Why is it important to get an MRI? And if you can't, what can you do?
Right, right. Very, very practical and very important question for our day-to-day setting. I think, of course, if we suspect a clinical cord compression where they have weakness, sensory level, I think we should start immediate treatment. We should start the corticosteroids to relieve any inflammation, any swelling, and of course, can always refer to the spine team and oncology team for an early assessment. Like in the second case, she did not have an MRI, but we were based on clinical findings and her PET CT, where we gave her the radiotherapy early. So I think it's good to always start steroids first and also get an input from us.
All right. So, just asking from a person who probably don't have oncology background. So, if you don't have an MRI, does your radiotherapy planning change?
Right, right. So I think if we have an MRI, I think we can visualize the whole spine, ideally MRI whole spine. So we visualize the area of interest and also if there are other areas that are impending cord compression, we can also include in our treatment. But if we don't have an MRI, we would probably give a bigger margin, like maybe cover two spines above, two spine level below, just to make sure we are getting the right side of pathology.
All right. Thank you. Uh, Fu in the audience has a question. What is the optimal time to give RT after a spine surgery, say posterior instrumentation? Maybe
Yeah, yeah.
Jasmine would like to take that
That's a very
question.
good. Thank you very much, Fu. Very good question. So normally after surgery, we would want the wound, the superficial, the skin wound to sort of heal before we give radiotherapy. Of course, we can always sim the patient probably a week plus after and also reassess prior to giving the radiotherapy just to make sure the wound is healed. I don't think there's any fixed timing as to when to give the radiotherapy, but of course, when they go in for surgery, oncology team would already be on board, so we would monitor and plan.
All right. I see very great response also in the Q&A session. Maybe I can relieve Jasmine also by answering some of them instead of
Thank you.
just putting Jasmine on the hot seat. Maybe we can get the first question. Many patients refuse decompression and opt for palliative RT with poor functional outcomes. How do you work with the MDT to convince patient to opt for both? Personally, I do not think that there is one right answer, especially in oncology. There are a lot of considerations, not just the outcome itself. To us may be really important, but to them may not be their priority because they do end up with a major surgery. And I think Jasmine also presented the certain criteria that possibly would benefit more from surgery. Of course, the advantage is that you get immediate relief, but the disadvantage is they may not be fit enough to go through um, a major surgery when they have really advanced cancer with poor performance status. So I guess it is important to lay out all the options for all the patients, I guess, and then uh, include the family because they will be the ones taking care in long term. And to have our surgeon on board and oncologist on board. And yes, we do have patients who mostly don't want to go for uh, major surgery, but I guess giving radiotherapy alone actually provides some relief if it is given at a timely manner and not wait until when the power has been zero for weeks and then unlikely they will benefit and have a neurological recovery. But maybe they will have better pain control in the long run. So the radiotherapy is not just made also for neurological recovery, but also the control of the bone pain, which I think answers the second question in the chat box where sometimes it overlaps with bone metastasis. So again, assessing the patient's symptom, the clinical presentation, and also correlating them with the disease tempo, disease biology, all is really important before you can just decide, okay, you go for radiotherapy. I don't think it's like as straightforward as that. And I think Jasmine rightfully mentioned that this is a teamwork. So of course, rehabilitation after that also is important. Uh, all right. Are there any precautions regarding the radiation exposure to rehabilitation personnel carrying out exercise in and therapy in post RT? Why don't Jasmine take this question if you are comfortable?
Sorry, what was the question? Can we exercise?
No, is there any concern about radiation exposure if, let's say, the rehab team is trying to
Ah,
provide some rehabilitation to our patients post radiotherapy? I think concern about radiation exposure.
right, right. That's a very good question and very practical question. I think we can be rest assured that radiotherapy is external beam. It's not from inside out. It's outside in, and patients don't radiate any radiation. So we're quite safe being around them. I mean, there's no concern. It's different compared to treatments like radioactive iodine, where they actually radiate, or FDG PET, where they also radiate some form of radiation. So our radiotherapy is safe for the public.
Yeah, so we really appreciate the rehab team helping us to also optimize the patient's care when they go home, especially PT and OT, and helping the carer to actually transfer or safely care for their patients as well. All right. I think we have someone in the audience who resonate a friend's husband slowly deteriorating while waiting for investigations. Given steroids and chemo took some time, and finally, chemo halted the progression with luckily some power left. And also, the second question, the last question, also actually somewhat ties it to chemosensitive malignancy. Can we get away with only chemo without radiotherapy? Uh, I think we had this discussion previously where there are certain tumors that are really chemosensitive, and providing urgent chemotherapy can be some sort of relief, or also some hormone sensitive tumors, for example, prostate cancer. So providing instant, let's say, subcut degarelix androgen deprivation therapy can provide some sort of relief. So you may be able to get away without radiation. So maybe examples of something that is very chemosensitive, maybe small cell lung cancer. But of course, the urgent chemo should be really urgent. And I think we only have a handful of urgent chemotherapies or urgent treatment. I'm not sure whether Jasmine agrees or not.
Yeah, definitely. I mean, prostate and small cell lung cancer is very chemo hormone sensitive. Then we start the systemic treatment first, and we would almost always expect a very good response.
All right. Okay. I think Chu from the chat also asked you about palliative RT to the spine. Mostly we see 20 grays, 5 fractions, 30 grays, 10 fractions, 8 grays, sometimes 8 grays, 1 fraction. How do we determine the RT regime suitability to patient? Maybe for those who do not know what is GY and hash, maybe we can explain to them. I didn't know before going into oncology. I was like, what is this hash? Yeah, maybe Jasmine can walk us through what does that even mean for 20 grays 5 fraction and different fractionation and
Right.
doses.
Right. So as I mentioned, the dose fractionation varies. We can give 8 grays, meaning the amount of radiation that we're giving in one fraction over 1 day. So it's normally one fraction a day. We also can give 20 grays in 5 fraction. It spans over 1 week, or in certain cases, we give over 2 weeks. How we decide, I think, mostly depends on patient factor and disease factor. I suppose patients who would have longer survival or shorter survival, probably shorter survival, we would give only one fraction just to ease the pain and symptoms, and easier for patient. They don't have to come every day. Or patients who have better prognosis, then we'll probably fractionate a bit longer. Normally we use 20 grays in 5 fraction over 1 week. Hope it answers the question.
Yeah, I think I agree with that. That often when you see, how come this patient get only one time? Some patients get 5 times, some patients get longer. Like Jasmine rightfully pointed out, that if let's say the survival is short, you want to save the patient the hassle of coming in every single day for treatment, then maybe one fraction is easier. And but to answer Chu, normally in exams, being in a exam center and academic setting. Normally, 5 fraction is the safe answer. And if you have like soft tissue components, maybe a more fractionated regime will be better. It provides better control and also less chance of retreatment, maybe meaning later patient receive radiotherapy again. So maybe you can ask Jasmine what does she think about retreatment. Let's say your patient has received radiotherapy before. Does that mean that this patient cannot receive radiotherapy again?
Oh, right. Not necessarily, but of course, it's a case to case basis. We should assess the patient definitely. I mean, symptoms, how long? Is the retreatment really indicated? Will we really benefit from giving another round of radiotherapy if the symptoms has been there for many, many weeks? We don't really expect neurological recovery, but maybe it's for pain relief, then it is a valid option. So retreatment is possible, but it's case to case. Assess the patient and what are we trying to achieve. Pauline, you're muted.
I'm so sorry. I think that is reasonable. I think, of course, when they say you have received radiotherapy before, doesn't mean that you cannot have it again. Of course, we consider things like time from the last treatment, what was the dose previously, and now we may make some modifications to the dose and the fractionation that we give the patient to see what we want to achieve, let's say pain control. I missed Fu's question in the chat box. If there's multiple level with cervical and lumbar spine metastasis, all 4 limbs, sensation and power deficit, which level should you treat first? Maybe both or only the cervical. Maybe Jasmine want to express her take in this.
Sorry, multiple levels. Multiple
Multiple
levels.
levels.
Right.
Let's say uh lumbar and cervical. That's Fu's question.
Ah, I see. I think and the clinical presentation is paraplegic, right? So I
Yeah.
think paraplegic mostly we would treat or suspect the level higher up. I would focus on the cervical level. Um, lumbar normally is where the cord ends and you have the cauda already. I mean the sacral plexus and stuff. So I think the cause would be from the cervical spine.
Yeah, I think probably you still have to go clinically and see which level it is which is affected and monitor closely whether it improves or not. But looking at the clinical presentation, if they are quadriplegic, then most likely higher up in the cervical. But there's no harm treating it together if the field size is not too big, I guess. But if he has no problems in the lumbar, let's say no pain, then if it's quality, maybe he won't have any sensation. Also, maybe it's not necessary. You can always treat it later too. So I think we still have to go clinically. And maybe we can take another question. P. Sarah Ahmad in the Q&A asks, have you explored reducing the dose and giving hyperthermia in conjunction? Maybe Jasmine want to share if she has any experience. Yep.
I'm not so sure about hyperthermia in cord compression. I'm so sorry. Pauline, do you have any experience?
Personally, I do not have experience by reducing the dose and giving hyperthermia. Like I think hyperthermia is an adjunct because if we go that radiobiologically, it does increase the effect of radiotherapy, but I think it is used in adjunct of the definitive radiotherapy. And also in terms of re-irradiation, also there are some papers that proves that it does help with improving outcomes as well. But in terms of like palliative radiotherapy, I do not think that we have enough data to support reducing the dose and then giving hyperthermia in conjunction. But this could be a good question
Yeah,
to, I think we have hyperthermia machine. Maybe this can be a student's project to investigate whether giving hyperthermia in conjunction actually improve the neurological deficit or the long-term outcomes for this patient. But thank you for the
yeah,
question. I think that's quite interesting since we have the
very
machine.
good.
Yep,
We
now.
can move forward with that.
Yeah, maybe some students in the crowd can use this as your thesis topic and explore this. All right. I hope that answers your question. And if you have any more, you can also answer. You can also ask in the chat box as well. Uh, I think probably we have answered most of the question. Maybe we give it another 1 minute or 30 seconds before we end. So while waiting, maybe we can ask Jasmine, what's your main takeaway and any word of advice to the crowd if they see something suspicious of crowd conversion.
Yeah, it's very common that we see patients we suspect cord compression, but we commonly want to wait for MRI. It's very difficult to get MRI whole spine because it takes a lot of time from the radiologist, and the MRI suite is always full. So first start with a basic chest X-ray to rule out, pathological compression fractures. We start with the corticosteroids. We can always get in the spine team, get in the oncology team just to assess. As I mentioned, case two didn't have an MRI. We can always use our CT simulation where we have a CT scan, of course, not diagnostic, but we can always sort of guess and correlate clinically where we want to treat with palliative radiotherapy. So
Yeah.
timely recognition, early referral, do not miss the ticking spine. That's what I want to say.
Okay. So I think hopefully what we get out of this is that the spine is ticking, hence the timely referral is really important. Not just referral, but also starting supportive care and subsequently preventing the long-term complications of cord compression, pressure sore, and also aiding them to recovery, especially rehabilitation is very important. So maybe for closing also, since we are advocates of timely referral, I guess it is fair to ask the crowd if they do need help, they can always contact us. Then we can uh, uh, lead them to a correct pathway of referral. Or you just want to ask opinion, you can always call our on-call MO. If they reject you, maybe you can ask us. Hopefully they don't reject you after also listening to this, that this is supposed to be a timely referral. Even if you don't give radiotherapy, I think we can give our input on the supportive care and also the subsequent, also be involved in like MDTs. So we can come up with a consensus together with the patient to make a good shared decision of what is the next right step. So you can call us through the operator, hopefully, and we will see how we can help you. So again, I'd like to thank Dr. Jasmine for highlighting this very important topic. Sounds quite simple, but very relevant to day-to-day practices. And we see more and more cancer patients who live longer and also have more and more cancer-related symptoms that require a lot of our care. So we well done for the presentation. And we are really grateful for Faculty of Medicine for giving us this opportunity, this platform to actually share our experience and also learn together with everyone addressing all the really, really good questions in the crowd. So you can also email us if you want to. You can find our email in the UMMC email as well. And don't forget to claim your CPD points by pressing the link on the chat box so that uh, you can also clock your hours to get your APC next year. All right. So thank you everyone again. I think we shall have a good day to get on with your clinical work and also daily duties. Really appreciate your time and joining us in this really meaningful breakfast at UM Health session. Thank you. Bye.